We're going to talk about the complications of labour and birthing, and if it doesn't all go to plan and you don't end up with a nice natural normal labour that you want, we're going to talk about how midwives and doctors can help with those different types of complications. We also usually talk about pain relief options, and there is an amazing link for pain relief options that we'd like you to go and watch so you can hear about your pain relief options around like TENS machine, Entonox and epidurals. So if you watch that, and then we're going to talk about the complications. I'm going to talk about some of the complications, and sometimes the way that the baby is lying can complicate your pregnancy, and it can also complicate your labour. So what we really want for your baby, when you're particularly getting into the later stages of your pregnancy, is that your baby is sitting in a head down position. Head down is the best position for your baby to be in. Up until about 36 weeks of your pregnancy, your baby can move and be in all different kinds of positions. So when your midwife is coming to see you and she's feeling your puku, she'll be feeling where the baby's back is, where the baby's head is, and she'll be writing that down in your pregnancy book. The closer you get to 36 weeks, the more we want to feel the baby's head down. We know that a baby's head down when you're in labour sits on your cervix and helps your cervix to open up, and this nice hard head is the best position for your baby to be in for labour. When your midwife is feeling your tummy, she's also feeling where your baby's back is, and we know in your pregnancy that babies move a lot, and so sometimes your midwife will see you and the baby's back will be on one side, the next time you see you it might be on the other side, and that is completely fine. What we are finding a lot these days is that babies' backs are often against mum's back. And when you think about the way that we sit often as Kiwis, we move our bottoms forward in the chair, we lean back, and so when you're sitting in this leaning back position, it encourages the main part of the baby, or the heaviest part of the baby, to be lying against your back. And when your baby's back is against your back, we call that posterior. This is fine in your pregnancy, but we do want you to practice sitting forwards sometimes. So when you're sitting forwards or sitting upright, it tilts your pelvis forwards and gets the baby into this anterior position where their back is against the front of your belly. We know that when you go into labour, this is one of the better positions for going into labour, and it's just good in your pregnancy to encourage the baby to be in this position some of the time. So instead of sitting back on the couch in the evening, at the end of the day when you're pregnant, maybe try leaning forwards. So leaning on a chair, tilting your body forwards, leaning over a Swiss ball or over a beanbag or something, watching TV, sitting forwards. And when you're in labour, we really like people to be upright or leaning forwards. Again, that gets this baby into this nice anterior position. We know that so you can push a baby out when they're in a posterior position, but we know that this lengthens your labour, which you don't want, and it also creates quite a bit of backache when you're in labour, when your baby is posterior. So an anterior position, much better. Also with your baby's head, when midwives are doing vaginal examinations, when your cervix is opened up enough that the midwife can get her fingers through and feel your baby's head, we are feeling for little markers on your baby's head to know which position they're coming through. And what we like is for your baby's chin to be tucked down on their chest so that this part of their head is coming through first. And you can see when they're in this position, it's the smallest part of their head trying to come through your pelvis first, and that fits the best. And we also know too when they're in this anterior position, so they actually come out when they've got their head out, they're looking behind. That is the ultimate way to push a baby out. It's the easiest and usually the quickest. So we like them anterior, chin tucked down, this part of the head coming first. When we're doing vaginal examinations, we're feeling for these markers on their head. So these bones and the gap in between is called sutures, and then they've also got these fontanelles. So it's quite a big one on the front there and a little one on the back. So sometimes we can feel those as we're doing vaginal examinations. If we feel that, we think, yay, this baby's in a really good position. And you push them out. Other ways that they can try and come, This is the most uncommon way that they try and come, is what we call a brow presentation. So instead of their chin tucked down on their chest, their head is extended and their little brow coming through first. And you can see with this baby's head, it's the widest part of their head trying to fit through your pelvis, and it doesn't actually fit. If we think that's a brow, we get doctors to come in. If they say, yep, that's definitely a brow, then you have to have this baby by cesarean. They will not fit through your pelvis. Brow is the most uncommon way for babies to come. Another way that they can try and come, and this looks incredibly uncomfortable, and I don't know how they make this happen, is that they can come through face first. And so that's when midwives, instead of putting fingers in and feeling this nice hard head when they're doing vaginal examinations, they put their fingers in and they're feeling all these lumps and bumps. And then eventually you start feeling that it's nose and mouth, and you start thinking it's little face coming out first. So babies, if they're in a good position, coming face first, you can actually push them out. But again, really, really uncommon. The most common way that babies come is exactly the way they're meant to, with their chin tucked in, that part of the head coming through first. So it's quite important in your pregnancy about leaning forwards, and also in your labour to be upright, leaning forwards, get this baby in a good position. Another way that babies can try and come, and instead of their head coming first, they can try and come with their bottom coming first, and we call this a breech presentation. So there's different ways that babies can try and come breech. Usually they have their little feet up by their faces, and so you're looking at just the bottom coming, and that's the most common way they try and come, and they can actually fit through like that as long as they're in a good position. Another way they can try and come is with their little feet tucked down, so you're looking at feet and bottom. That way not so good, they're not going to fit through. And they can also do tricky things like have their little feet dangling out for part of the labour as well, which again can complicate things. So if your midwife is feeling your belly and in your pregnancy, and she feels like the baby's in a breech position, she can feel the head wobbling around up here, usually we get you a scan, and they scan the baby. If this baby stays in a breech position, we can get you into the hospital to see one of our doctors, and they can try and turn the baby. They just do that through the skin on your puku and just try and turn them into that head down position. Sometimes it works, sometimes it doesn't. Sometimes they get the baby so far and it's uncomfortable for mum or whatever, and they just stop. If they can get the baby turned, you can go on and have a normal delivery. If they can't get that baby turned, what they're doing at the moment is they offer mums a cesarean for a breech birth. You can decide whether you take that option or try a vaginal delivery, but the bulk of our breech babies born up here in Northland are born by cesarean. You get a day that you get booked in, you come into hospital and you have that baby by cesarean. It's a bit tricky for first time mums because you don't know how you're going to labour, how your pelvis is going to go with labour, and how you're going to go with pushing a baby out when you've got this soft bottom coming first rather than this nice hard head. You definitely need to be in hospital, you definitely need to have midwives around that know what they're doing as far as breech deliveries, and doctors there for just in case. So that baby coming breech can absolutely complicate things. So if other things that we can do, and one of the really more common things that we do in delivery suite, and definitely on a weekly basis, sometimes a bit more, is induce people. And so I've picked up this random looking instrument here, but induction of labour, a medical induction, happens in the hospital. Okay, so there are some little things that you can do beforehand to try and make your body go into labour. There's things like eating heaps of pineapple, eating dates, having sex. Having sex needs to come along with a hot bath and hot curry. We'll let you try that out. But also going for walks, that kind of thing can encourage a labour to come on. But things that midwives can recommend is evening primrose oil and raspberry leaf tea. So the evening primrose oil comes in those little capsules, and your midwife will direct you how to take that, and then you drink this raspberry leaf tea. You can also get capsules of the raspberry leaf tea. If you don't like the tea is not very nice, but you'd only do those things directed by your midwife, so just check with her first. There's also another little technique that midwives have got called a stretch and sweep, And so you have the option of taking this on board or not. If your midwife talks to you about it, she can do it in your home, she can do it in her rooms. It doesn't have to be up at the hospital, but your midwife does a vaginal examination. She'll only do this once you're overdue. She won't do it before 40 weeks. But she does, so you, the same deal, take off your pants and undies, lie down on the bed, flat on your back, covered up with a sheet or a towel, and your midwife does that vaginal examination, and we're feeling your cervix. If your cervix is tight and hard and closed, she kind of forces her fingers just inside your cervix and does a stretch and a sweep with her fingers. She has to do this action 3 times for it to work properly, and it is uncomfortable. It's not very nice having it done. But what that does is releases a whole lot of hormones around your cervix, and once she's done that stretch and sweep, you might get some niggly pains, some sort of period type pains, your show might come away, and then it'll all fade away. Not much happens after the first one. She comes back 2 days later and does another stretch and sweep, again niggly pains. Sometimes you go into labour, sometimes you don't. And 2 days later, the third stretch and sweep is usually when you go into labour. So if you're signing up for one, you kind of need to sign up for 3 of them, potentially. But if you don't want to have that done, you don't have to. Your other option is to be induced in the hospital, and you come in and see the doctors that explain the whole process, and if you say yes, I'd like to be induced, then they book you in on a day. The most common reason that we induce people is because they go overdue. We used to let people go to 42 weeks, so 2 weeks past their due date, but now we say 7 to 10 days. We know that placentas have got a use by date, and the more you go over that 7 to 10 days overdue, the more we don't know how your placenta is functioning and how the baby's coping. So we do like people to be induced. It is your choice to be induced or not. But if you say yes, you come into hospital, usually 7 o'clock in the morning. Your midwife meets you, they check you and the baby out, and then she does a vaginal examination. And we've got this, an applicator, it's full of gel, it's called Prostin, and we do the vaginal examination and we squirt this gel in around behind your cervix. You have to lie on the bed for an hour to make sure the gel stays around your cervix. You're monitored to make sure the baby's okay. Then you can get up after the hour and walk around maternity. After 6 hours, your midwife will do another vaginal examination. If your cervix is still tight and closed, more gel goes in. So we repeat that gel every 6 hours until your midwife does a vaginal examination, and if she can feel your cervix is opening up, sometimes we can feel the bag of waters with the end of our fingers just coming through the cervix. If we can feel your bag of waters, then we break your waters. And that's where this nifty little tool comes in. So we put our fingers inside your vagina, we're feeling the bag of waters, we run this up our hand, scratch it across the bag until it breaks. There is a tiny, tiny little plastic hook on the end of this. So it just catches the bag and pops it. It's not hurting the baby, not hurting mum. Once we know that we've broken your waters, all those waters drain away, and then we leave you for about 2 to 3 hours to see if you go into labour yourself. If you don't, then the third way that we've got to induce you is you put a drip in your arm or in your hand with a bag of fluids, and that just slowly drips a hormone into your body that makes your uterus start to contract. So we always start with the gel first, then we break your waters, and then it's the hormone drip. People that have been induced in the past that I've talked to and have got the comparison of an induction to a normal labour say that an induction is more intense because we're forcing your body into labour. So you're more likely to need some pain relief, and then because you have pain relief, you might sort of be starting on that pathway of intervention. It's not necessarily for everybody, but for a lot of people you do need some help to get through an induction. But you'll have that discussion with a midwife and with your doctor if you need it.
So Monique was mentioning how having an induction can often lead on to pain relief, like the stronger pain relief like your epidurals, which mean you might need help getting baby out. Some women have the epidural and can still feel the pressure to push. Others do need that help because they haven't quite got enough feeling to push baby with their body. So there's several ways we can help. It's done by the obstetrician, and they'll come talk to your midwife, see what's been happening. They'll do a vaginal examination, check baby's position, and then they'll work out how they're going to help. Most babies are low enough down that they can get them with the Ventouse. So we have plastic ones and there's also metal ones. And this goes onto baby's head and they pump it up to create a vacuum. And then as you're pushing, they'll be pulling. Contraction stops, baby's happy in there, we wait. Next one comes, you push, they're pulling until, oops, we're stuck, until baby's head is out. And that's when they take that off. And we just wait for baby to do their little turn. And you give that final push, and baby's out. Now with the Von 2s, because it is vacuum suction on their heads, they end up with a wicked cone head. So hats are great for a couple of days. And people come along and go, oh, have they got hair? And you're like, no, just leave it be. The bones settle down a couple of days and then a little bit longer for the bruising. They heal really well. So if baby was distressed though, while the doctor's trying to get them out this way, they would do an episiotomy and they wouldn't wait for you to push. But that's only if baby got distressed. Most babies are happy enough, they're just taking their time, coming out in their own time, and just need that extra little bit of help, that last bit. The other way is with the forceps. This is for babies that's still quite high in the pelvis, and it's often done down in theatre. Just in case they can't get them out vaginally, they're in the right place to do a cesarean section. So the forceps look like salad tongs and they lock in place so they're not squashing baby's head. And then they put them in and around, in and around. Oops. Lock them in place. And again, as you're pushing, they'll be pulling. And it's a bit of a wriggle because babies don't come like sliding straight out. They do actually wriggle their way through the pelvis. So it looks a little bit brutal, but they're guiding the way the baby would naturally come out. Once the head's out, remove the forceps. And again, wait for the baby to turn, and you do that final push. And the forceps come around the side here. So they can have little cuts and bruising, and again, they heal really well. And for the forceps delivery, they would need to have their chin tucked right down. It's the same as we like them, the best position like that. If their head was extended, it would be a C-section. So if the head's tucked, they can help guide baby out that last little bit. Okay.
Right, so another complication can be if you can't actually get your baby out. And so there are some reasons why we do cesareans. So if your baby is getting distressed and you're not close to having a baby, if you started to bleed and we weren't sure where the bleeding was coming from, if your baby's in a funny position that we're not sure how they'll come out, if there's any kind of complications with mum, then there might be some of those kinds of reasons where your midwife might start thinking that you might need a cesarean. If she's thinking that, she'll call in a doctor, whatever doctor's on call, so that would be an obstetrician. And if they felt the same, if they're like, yep, for whatever reason we need to go down to theatre, they would talk to you, make sure that they've got your consent, and then they would start the process of going down to theatre. So Whangarei Hospital is a bit random the way it's set up, and that maternity is at one end of the hospital, and theatre is about as far away as possible from maternity as you can get. So it is a long trip through corridors and down a lift to get down to theatre. So in Whangarei Hospital, our process around going to theatre is that if there are other staff members available, we get a group of people into your room. So you may have seen no other staff members, and then all of a sudden different people are coming in and out, asking you different questions and getting you ready. There's a whole checklist of things that we need to get as organised as possible on maternity before we leave to go down to theatre. So they'll have a name tag on you, you signing forms, they put tight white stockings on your legs, and that's to encourage good circulation in your legs while you're having an operation. You can bring one support person down to theatre with you, and usually we get them to push a really big incubator. So the great big plastic beds that they can pop babies into, they've got the holes in them so you can put your arm through and touch the baby. And we always take those down to theatre just because theatre is such a long way away from maternity. Rather than walking back up through the corridors holding a brand new baby, we often pop them in the incubator where it's nice and warm, they're safe, and then push them back up to maternity. So an incubator goes for every single birth that's happening down in theatre. So you get to bring this one support person down with you. Once they've got you all organised in maternity, usually your midwife or another midwife that you've become familiar with will go down to theatre with you. So you've always got a familiar face. A porter comes up from theatre, we pop you onto a special bed, and then we push you through all these corridors. In the daytime, there are people, departments are open, it's quite weird. In the nighttime, it can be quite dark and quite quiet, and they're pushing you through the corridors. So it's a bit of a weird ride down to theatre. But once you get into the lift and down into theatre, then it's just the theatre staff down there. When we get down to theatre, your midwife hands your care over to the theatre staff, and then they kind of take over, but your midwife stays with you. Once you're in theatre, the woman having the caesarean goes off into the theatre. The person that is there for your support, as your support, gets taken away into a changing room, and they get to wear the blue top, blue pants, and sit in a waiting room until the person in theatre is ready to go. You just stay in that waiting room, and you end up sitting there for quite a while. You feel like they forget you. They will not forget you. They will come and get you. When they do finally come and get you and take you into theatre, the person having the operation will have been put into, so definitely up in maternity, we'll get you transferred into a gown. So this is a hospital gown. They always get done up at the back. When you're going down to have a caesarean, you wear nothing underneath. So no bra, no undies, and just these tight white stockings that I was talking about before. So once you're in the gown and in theatre, there's quite a skinny little bed in the middle of the theatre that they lie you on. You're lying flat on your back. So flat on your back, with your arms usually out on these side panels. That's because you've got a blood pressure cuff on one arm and a drip usually in the other arm. They lay you down, and then pretty much from chest down, you're completely covered up by a big sterile sheet. That sterile sheet comes up to chest height and then comes up and out to make a great big screen that sits up above your face so that you cannot see what's happening on the other side. They usually pull in a chair beside you, so when your support person comes in, they're sitting right beside you on a chair in behind that screen. So you can't take photos, you can't take videos. You can give your phone to the midwife, and the midwife can try and get some photos, but you just need to see on the day who's available for doing that kind of thing. Support person sits behind you, and the other person that's behind the screen with you is the anaesthetist. So they are constantly checking in with the person having the operation, making sure they're feeling okay, making sure they can feel nothing with what's happening with the operation, and they can fix all that kind of thing. If you are starting to feel sick, if you're not feeling okay, you need to talk to them. They're your person to check in with. When they've got the big drape on, the obstetricians that are all sterile are standing on either side of your body, and they only start doing the operation when they know that you can feel nothing. They check a number of times before they start doing the operation. Well, these days caesareans are down quite low. We call them a bikini line cut, so down low, just big enough to get a baby's head and body through, so they're quite small. And when they start doing the operation, from the first cut to getting the baby out, if the baby's completely fine, they're not distressed, it can take sort of 7 to 10 minutes to get the baby out. If they know the baby is distressed, they can get them out really quickly, like up to 5 minutes and the baby's out. So the bit cutting in and getting the baby out is quick. Once they've got the baby out, usually they push on the top of your belly and push the baby out. Once the baby's out, they give them a dry with a towel, and they usually pop them up over the screen so you can kind of see what they look like, and then back down again, and then they hand the baby over to either a paediatrician or the midwife, whoever's down there, on a special resuscitation table that is there with all the bits and pieces that may be needed for the baby. Once you've got the baby all wrapped up in a nappy on, then the baby gets brought around to the support person. So support person will be sitting beside mum, holding the baby, checking them out, and they're a great little distraction while they are doing all the sewing up after the operation. So the sewing up can take up to 40 minutes. There is a number of different layers that they need to sew up again. It takes a long time, and they're doing it very carefully to make sure that next time you get pregnant, it's all good to go and healed for next time. So 40 minutes of sitting down there with the baby, holding the baby. Your midwife would come around too and be checking in, making sure that baby's okay and that you're all okay. If they see the baby doing a bit of this, looking like it's looking for something or looking a bit hungry, sometimes they put their little tongue out, or sometimes they put their fist in their mouth and start sucking on it. If they see that the baby's starting to get hungry, that's why these gowns open over the top. So we can undo them. So you'd have nothing on underneath, so it would be bare skin, and the baby has usually just got a towel wrapped around it, so it would be skin to skin. So the baby's head over your shoulder, the midwife would be standing here holding the baby the entire time, making sure that they're safe. So we start with skin to skin, so you can kind of see them and do that. But then if the baby keeps going, doing lots of this and getting really hungry, then we move the gown down over mum's breast, and we can actually attach the baby to mum's breast for their first breastfeed. And that is while they're still doing all this stitching up from the caesarean wound. So just because you've had a caesarean doesn't mean that you miss out on skin to skin and a nice early breastfeed for the baby. So that happens as long as they're doing that. Midwife standing here holding, and as soon as they're finished, they need to stop what they're doing, then the midwife can take the baby and give you a bit of dignity again, do you up again. And then you all go together, usually from theatre, once they've finished with you, to a place called recovery, which is still down in theatre, with theatre nurses looking after you. They're just making sure your bleeding's okay and that your pain relief is under control. Often baby and support person stay with you, but if it's really busy, sometimes they get them to go back up onto maternity. But like I say, usually you stay together, you're there for about an hour, and then you go from there back up onto maternity. You get your own room, you get your own midwife or nurse to look after you for the first 24 hours after a caesarean. You don't get up and move or do much at all. You're pushing the buzzer every time you need the baby. People come in and help you. They're doing lots of different checks and things, making sure that you've got all your pain relief medication. But then the next day after the caesarean, they get you up and about. We know that if you get up and get moving gently, then you actually heal better and your body recovers better. So we get all your drips and bits and pieces out. You can go back to picking up the baby, sitting and breastfeeding, and just being careful of yourself. So average stay in hospital after a caesarean is 3 to 5 days, but it's totally up to you. You can decide however long you stay for, but you get amazing care in Whangarei Hospital. There is one little bit that I forgot to do, and that is how many people are in theatre. So usually with group work, we use a bit of the group, and we go through lots of different people that will be in theatre. So it can be quite overwhelming in theatre when you see how many people are there. So you definitely have a couple of nurses. So there are extra pairs of hands. You might have a midwife. Sometimes if your own midwife wants to stay, she might be there as well. You have a nurse supervisor. You have a scrub nurse, and she is offering all the equipment to the doctors, and they're all sterile. There's the obstetrician who's doing the operation. There's a house surgeon. They're a doctor that has done all their doctor training, but now they are specialising in obstetrics. The paediatrician might be there for the baby. Your anaesthetist is making sure that you're comfortable and pain relief is sorted. There's a technician that helps the anaesthetist. And then Whangarei Hospital is also a teaching hospital. So you may get asked if you can have a student midwife or a student doctor or a student nurse at your birth. It is totally up to you. If you're happy, you say yes. If you don't want them there, you can absolutely say no, and they will not come into the room. So this bit is up to you, but all the rest of these people will be in theatre, milling around with their theatre garb on. They all come up and say hello. They all say what they're doing there. You will never remember them again, but they're all caring for you, your baby, and your support person that's with you. And they're lovely down in theatre.
With a C-section, they actually take the placenta out through the open wound, and people say it's a really weird feeling when you're having a C-section done because you can't feel anything, but it's because they're trying to get baby out. It's like someone's doing the dishes in your tummy, but it shouldn't hurt at all. The recovery as well after a C-section is 6 weeks, so you need to be really careful of that wound. It is major surgery you've just had. So yeah, just anything like stretching up to hang washing up, Even driving your car, make sure you're covered on the insurance, because some companies won't cover you within that 6 weeks. So just being sensible and not putting any pressure on that wound for the 6 weeks while it heals.